we're trying to follow the agenda as much as we want. And second speaker on there is Andrea. Andrea, who is a clinical nurse specialist at the Nottingham University, so in the United Kingdom. Andrea is a pediatric, a clinical nurse on pediatrics, as I told you, and she will do an interesting session on burns management in children. So Andrea, the floor is yours, and please everyone, you can keep on asking questions in our chat box.
Hello, my name's Andrea and I'm a children's nurse specialist at Nottingham Children's Hospital in England, and we're famous for Robin Hood, which is in our Nottingham Children's Hospital logo. So I'm just going to check, can you see my slides?
Yes.
Yes, perfect. So the aim of this session is to give a brief overview of children's burns. So some of it predominantly is going to be from the UK perspective. So we're going to look at the statistics, the mechanism of injury, burn size estimation, wound management, toxic shock syndrome, safeguarding, burns prevention, and the multidisciplinary team. So worldwide, unfortunately, there are 180,000 deaths every year, and they are predominantly from fires, scalds or electricity. Within the UK, about 0.5% of our population suffer burns, and these statistics are predominantly from adults and children. Only 10% of that 0.5 require hospitalisation, and 1% will have life-threatening injuries. As you probably would expect, most of them occur in the kitchen and bathroom, and a lot of the burns that we see are due to carelessness, and contributing factors such as alcohol and smoking cause some of that as well. So for children, 26,000 children within the UK under the age of 5 are burnt or scalded in the home each year. And every 2 hours we have children less than 18 attend our emergency department. And then every day 13 children under the age of 5 are admitted to a hospital or scald. Now these statistics are from only the patients that are admitted to a burn service, and do not include all the patients and children that get burnt that attend emergency departments or walk-in centres or their primary care facilities. So the figure potentially might be a little bit more. But last year we saw 7,061 children burnt, which is huge amounts. Within Nottingham, so within my burn service last year, we cared for 476 children, which is about on average what we see every year. And we work very closely with 2 other centres within my region. So we work with Birmingham Children's Hospital, which is a centre, and we work with Leicester Royal Infirmary, which is a facility. So on average, our figures are all on comparison. So for our region, we do care for a lot. Recently, during COVID, during the first lockdown, we did think we would see a lot more children come in with burns. However, we were wrong. We saw an actual decrease within patients coming into emergency departments and into the services throughout the UK. But as lockdown relinquished, the services were needed again, and we saw more children getting admitted. And this summer has been one of our busiest summers. The figures for the second lockdown that we're currently in is yet to be sort of seen, but we are still busy coming into winter. So how do children get burnt? Predominantly, the main reasons children get burnt are from scald injuries, contact injuries, flame injuries, electrical burns, and friction burns. So within children, 70% of scalds, 70% of the children's burns are caused by scalds. So this could be either predominantly hot drinks, where we see 180 children a day get burnt by hot drinks. It could be bad baths, kettles, food, any sort of liquid. And we are coming into sort of bath season, so we tend to see a lot more children having scalds from baths. So this picture here is a classic pull down drink injury. A little toddler that's poured a hot drink down themselves, and it's got the classic sort of V-shape distribution. Following on from skulls being the most, the next category that we tend to see the most of is contact burns. And 40% of children's burns are caused by touching something hot. So that could be hair straighteners, irons, hobs, cookers, radiators, log burners, anything where there's something really hot for them to touch. And we tend to sort of see a lot more hair straighteners in my experience during the winter. Maybe we're coming up to party season for Christmas, but that's what we tend to see. But this picture here is a picture of a toddler that's walked across a hob. So that's across the top of the oven. We tend to see a lot of children do this when they're climbing up drawers, trying to get to the sweets cupboard or the biscuits cupboard, which most parents seem to keep above the hob. So it's an activity that we do see quite a bit, sadly. And obviously hair straightener burns, as you can see in this picture, again, they are very, they can be very damaging, and they do cause really, really deep burns. So flames, 14% of our burns are caused by flames, and that could be anything from candles, costumes, Halloween costumes, clothing catching fire, barbecues. We tend to get a lot of serious burns in the summer because of barbecues, or some of the teenagers playing with aerosols, and they are deep and they can cause really, really nasty burns. And here's a picture of a young man that we had over a Christmas period when his pyjama top sadly caught fire, and he sustained quite significant burns, as you can see. So for chemicals, we only see a small amount of children get burnt by chemicals, but these burns by chemicals, they tend to be deep and they're corrosive, and until that sort of chemical has been removed, they will keep on burning. And depending on how they get burnt, whether it's an alkaline burn or an acid burn, they can cause differing burns, with the alkaline burns causing sort of deeper burns. And we tend to see children getting burnt through cleaning products, doing some challenges called the salt and ice challenge. I don't know if you've heard of that, where they put some salt on their hands or their arm, cover it with some ice, and then they get a deep burn from that. And we've had lots of children needing skin grafts following that deep burn. And we tend to see this sort of challenge in the summer when the kids go back to school around the September months, when they learn new tricks that they get at school. And we also see a lot of children, we've increasingly seen children coming in with black henna tattoos. So when they've been away on holiday, they've had a black henna tattoo in the holiday resort, they get it topped up again, and they develop an allergy to it. And we've seen lots of children with these injuries, sadly. So moving on to electrical burns, 1% of our children sustain burns through electrical sources, whether that's chewing through wires, putting little fingers at the back of fridges and getting electric shocks, or putting in electric sockets. Most of them are from the domestic voltage we get, so we don't see many sort of major injuries with the children, but they can cause lots of difficulties, and they can need very close monitoring if they do have a significant electrical burn. And here's a picture of a young child that's chewed through electrical cables, which can be take a long time to heal. Friction burns, they cause a small amount of the children's burns, about 0.5%, but in my experience, the children that sustain friction burns, they're often small. They get them by treadmills, through vacuum cleaners, or through road rash from being in a car accident, or being falling off the bike, for example. We have had studies, we've done a study locally within our hospital and looked at a case series of children. These burns caused by friction burns, they are predominantly small, but they can cause life-changing injuries, especially from the treadmills. If they get their little hands stuck on the belt, it shears off the skin. As in this picture, which is showing now, it shears the skin off on the hands, and they can have sort of life-changing injuries and potential problems with the movement of the hands. And it's really, really sad, really, but we have seen more treadmill burns during lockdown, so because gyms have been closed, people have been having treadmills at home, so we have seen a dramatic increase in our service from this. So following on from all these children getting all these different mechanisms of injury, we need to make sure that these children have good first aid. So the aim of the first aid, as was discussed previously, was to stop that burning process, provide some pain relief, and make sure the burns are covered up. So we want to cool that burn with cool running water for 20 minutes. We want to call for help. So in the UK, we call for help through 999 111 or a GP, and we cover that burn with a cling film or a non-fluffy dressing and make sure the patients kept warm. This is what we promote within our service, and we have magnets, and we work in conjunction with the Nottinghamshire Fire, and that's why their logo's on the bottom as well. So once someone has sustained a burn, there is many different tools and mechanisms which are available to people to estimate a size of a burn. So for children, there is something called the rule of nines. This is predominantly an adult tool which has been adapted to children, and where the body's broken up into 9 sections. Children have a larger surface area on the head compared to adults, and we take percentages of the head and put it on their legs as the child grows. Lots of people find this confusing in my experience, because in an emergency, when you're trying to work out an estimation of a child, it can be confusing for people. So it's one that we don't routinely use sort of in my service. We do have something else called the Palmer method, which a lot of people are familiar with, where it's the palm of the hand, and that's 1% of the hand, and that you need to make sure it's your hand, the patient's hand, on their own body, and it's not your hand, because you could get miscalculations that way. The other 2 ways they're called the London Browder chart. The London Browder chart, it comes in lots of different ages, and I think it's routinely used in a lot of hospitals. We have it in ages from a baby, 2-year-old, 5-year-old, 10-year-old, 15-year-old, and adult. And you draw on the map, the body map, and then you can calculate on the right-hand side where that child has been burnt, and total up at the bottom to give you the total body surface area for the child. Moving forward, we use something in the UK called the Mersey Burns app, and this is becoming more and more used within all our emergency departments. It's an app which was designed in the UK, and it's really helpful for inexperienced staff if they are not quite sure how to work out the body surface area of how much a child's been burnt. You literally draw on the app, and it calculates it for you, and it calculates and tells you what to do. And it has been proven, some studies, it has been more accurate tool to use rather than the London Browder, the Palmer, or the rule of nines. But it just depends on how experienced you are and confident at doing total body surface area estimations. But when you are calculating percentage of burn, you have to really make sure that you make sure you don't count the unblistered skin. You only count blistered skin when children have been burnt. So once you've worked out the estimation, we've got depth of burn. So we categorise our burns as erythema, superficial, partial thickness, mid-dermal, and full thickness. So we've got some pictures here showing the different categories. In my practice, we have a lot of parents who will ask us, is that a full thickness burn, second degree, not full thickness, first degree burn, second degree burn, third degree burn, fourth degree burn? And when you question them and ask them, do they actually know what that means? It's often they don't know what that means, and it's just something they've picked up on the television or from movies. So we sit there and we discuss all the different types of burns, and make them sure they understand the categories, to make them sure they know what's going on. So burns in children, they are often small, and they are minor and small in size, which is very good. However, burns which have an estimation of 10% or more, they're classed as a resuscitation burn, and that's when things become a little bit more serious, and they require treatment straight away to make sure their systemic inflammatory response is dealt with, because they can lead to shock and death. Within children, it's 10% or above is classed as a recess burn, and in adults it's 15%. Some of our teenagers, we do calculate them at 15%, depending on their size and their age, but then that's down to individual sort of judgment. From this picture here, you can see a picture of a young boy that was burned quite significantly in a bath. You can see the skin is turned to tissue, a tissue-like appearance, and this boy was approximately about a 45% burn. And again here there's a picture of a young child who's had a pull-down injury. They've burnt their face, shoulders and necks. The predominantly concern for this one would be the airway management, to make sure they can continue to keep their airway patent and breathing as an optimum. When children do have a burn above 10%, they will require some quite in-depth treatment. They will require resuscitation fluids. So we would advise to put sort of 2 cannulas in. They would have maintenance fluids going. That can either be taken orally or through an intravenous route. And they will have resuscitation fluids. That will be either through something called the Parkland's formula or the Muir and Barclay formula. In my practice, my clinicians prefer to use a combination of both. So we use Parkland's formula for 8 hours and the Muir and Barclay following the 8 hours from the time of injury. But I know that differs depending on which burn service that you work in. We would recommend putting a urinary catheter in, because we need to really keep a close eye of the urine output to make sure they're averaging about 1 to 2 mils an hour of the urine output. If they've sustained an electrical burn, we need to keep an eye on the colour to make sure that the urine's not getting pigmented. So we might need to give them more fluids, for example. Close monitoring of the vital signs. We need to make sure we keep an eye on their temperature, their pulse, the respiration, their blood pressure, the capillary refill, just to make sure they're all within normal parameters and what we would expect. We would insert a nasogastric tube, because feeding would be an optimum to help burns heal. This becomes a little bit more difficult if they've had a pull-down injury and their face is badly scalded, but there's ways that we can sort of work around that. And ideally, we would like them to be nursed on a HDU environment or an intensive care environment. However, they can be nursed on wards, and they are nursed in wards in my hospital. But it depends on the nursing acuity and the dependency of the other patients when we make an assessment of where is best for those patients to be cared for. As you would expect, burns are extremely painful if anyone's ever experienced a burn, and for children it's a very scary time for them. So to ensure they understand what's going on, we must distract them. We must provide excellent distraction for them. So we tend to use IN fentanyl or diamorphine for pain relief. We also use oral morphine, paracetamol, ibuprofen to make sure that they really adequately have a good analgesia on board, and we have good distraction. So that's whether we use bubbles, like in the picture. We use a lot of bubbles, but currently during COVID, we're not doing that so much at the minute. Toys, books, videos, the little DSs they like, anything to keep them distracted, because we want them to have very good compliance. So in an ideal world, we would want a dressing for any burns patient, with regardless an adult or child. We would like it easy to go on and easy to come off. So when we have a wound, we will clean with saline or a dilute antiseptic. We'll de-roof the blisters, so that will allow us to gauge the depth of the burn. We will ideally apply silver dressings. In children, we don't give prophylactic antibiotics anymore. Historically, we used to for the prevention of toxic shock, but we don't do that now. We use silver dressings for their antimicrobial benefits. So dressings that we use predominantly, these are some of the dressings that we use within my practice, and are readily available, I believe, around Europe. So during COVID, we've changed our practice slightly. Parents are, before children would come back to our dressing clinics for regular review, but we've reduced the footfall within our hospital at the minute. So parents are doing a lot more dressings at home for them with support with us through email, on the telephone, through video consultations, through WhatsApp, any secure method that we've got and they feel comfortable using, we've been able to do. So we use any kind of dressings. We have Ergotor, we have Flaminol, Silfex, Actico, Aquacel and Duoderm. So depending on the dressing and depending on the needs of the child, we will tweak the dressings to the wound. So for smaller dressings and bigger dressings, we use some of these. For bigger burns that we would take to theatre for a clean and debride in theatre, we would use some dressings called BioBrain or EpiProtect. So BioBrain is a biosynthetic dressing and it's got collagen derived from pig skin. We use this dressing for a long time and we still use it occasionally in practice. But due to our sort of cultural diversity of our patients, we had a lot of patients refuse it because of the pig's collagen, and they declined it and went with conservative dressings. So recently, since about 2018, we've been using a dressing called EpiProtect. It's a cellulose dressing with no animal or human products in, and is on the right. We have some very good results with it. The BioBrain, we tend to use it for superficial or partial thickness burns, and again we use it with the EpiProtect, but you can also use the EpiProtect on full thickness burns, and we do have extremely good results with this. So children, sadly, when they have a burn injury, they are more predisposed to having toxic shock syndrome, and this is the most common cause of unexpected mortality, sadly, and 2.5% of the children who are admitted with a burn service have toxic shock. So it's predominantly caused by a Staphylococcus or Streptococcus toxin, and as like I said, it can lead to death and multi-organ failure. It's often missed because of the non-specific signs of toxic shock, and they can mimic other childhood illnesses. Children present with a temperature, not eating and drinking, not passing urine, being a little bit more sleepy than normal, a rash, or just generally parents will report that they're not themselves. And that could be anything in children. It could be teething, they could have a viral illness, they could have a urine infection. So children under 4, unfortunately, are more at risk of developing toxic shock because they've not been predisposed to the toxins caused by the bacteria. So treatment from this, if they do present with it, is very immediate treatment, and starting the sepsis bundle sort of protocol, or your protocol for your hospital. And here's a picture of a young patient with toxic shock. You can see he's got the rash. You can't see his face, but you can see that he looks poorly and not very well indeed. So in my experience, we probably get 1 to 2 of these children a year with toxic shock, which is not nice to see, but it's nice to see when they get better. So unfortunately, with children, when they do sustain a burn injury, we do have to be thinking about safeguarding. So most burn injuries that we come across, they are accidental, but there is between a 5 to 14% chance that these burn injuries that children sustain have been a result of abuse, whether that's deliberate neglect or whether it's an inflicted injury. Within my service, we have an average of about 9% of the children that we see come in with some safeguarding concerns. So some pictures of here of children that have sustained some deliberate injuries. So the one on the left, it looks like it's been branded, and that's actually by a hair straightener, not hair straightener, hair dryer. The vent of the hair dryer has been deliberately put on the abdomen. And then on the right hand side, it's a deliberate hands being held in a hot drink, because you can see the distinct line there on the hands. That's called a dip-in. So when a child does present with a a burn, you do have to sort of ask yourself lots of questions. Is there any red flags there that you need to be concerned about? You need to look at the age of the child, the nature of the injury, the consistency of the injury with the history. Does the burn that you see in front of you, does it actually match what the parents are telling you? Has their story changed at all? Because when you ask the parents sometimes to repeat the story, with whether it's to a nurse or a doctor, they do sometimes. The story changes a little bit and there's little variance in it, and that becomes a red flag. Was the child being supervised when the accident happened? The data presentation, when did they seek any help? Did they leave it a couple of days before they sought medical help, or did they take a little bit longer to seek help from any sort of healthcare provider? Have they got any significant past medical history? Do they have lots of attendances at A&E? Do they have any previous burn injuries? All these things need to be considered when taking the story of a burn. And then subsequently refer to your local safeguarding team, social care, and even the police if required, and make sure these children are closely followed up and they have the right support in the community as they need. These pictures here, I don't know if you recognise any of these children. They are Victoria Cumberley and Baby P. These are two children within the UK service who sadly died. And when there was serious case reviews, they found out that these children initially first presented to the healthcare sector and the social care sector. They sustained a burn. So it just demonstrates that burns can be sort of like the first indicator that something's not going right in that child's life or in that family, and then this family might need a little bit of extra support and guidance. So it's very significant that we keep an eye on these injuries and making sure that the families do have the right support, whether it's school nurses, health visitors, referrals to social care, to make sure these children are ultimately kept safe. So ideally, prevention is better than cure, and we do a lot of burn prevention within my service and within the UK. Every October we have National Burns Prevention Day, and that's when all burn services do lots of work to promote burn safety. And with our British Burns Association, we all link together. We have regular meetings to a prevention group to make sure we're all saying the same sort of message for that year. We work with local fire services, local emergency departments, local children's centres. We do teaching in schools, just to make sure the message is getting out there and children do know what to do in an emergency, and if anything does happen when children, are sadly burnt. And we work quite closely with charities in the UK. We have something called the Children's Burn Trust, and we work really closely with them as well. So ultimately, none of this could happen without lots of people, and we have the Burns Multidisciplinary team. So within our team, we have lots of people. We have burns outreach nurses that go out to people's homes. We have psychologists, we have nurses, we have surgeons, anaesthetists, physios, OTs, dietetics, liaison health visitors, and the play specialists, who every one of these members provide a vital role in a child's life. We all work together. We have a coordinated approach to make sure that a distressing and upsetting experience for the child and the family goes as smooth as possible. And that happens regardless whether a child is just attending for one dressing or attending for many years, because lots of children will attend a burn service for many years and require quite in-depth treatment. So by having a coordinated approach and working together, we're there for the children and to make sure they're ultimately safe and get better. And that's it. Thank you. Has anyone got any questions?
Thank you, Andrea. Thank you very much for this very interesting presentation on children's burns management. And indeed, there are quite some questions popping in for you. Be prepared. A first question we got. Recently, I saw a young boy sent home with a facial superficial burn. parents were told to cover with Vaseline, no dressing. I covered this at night for fear of sticking to bedding or fibers sticking in wound. What are your thoughts on this?
So in our practice and with our service, we tend to use yellow soft paraffin, which is like Vaseline. We recommend to clean the burn sort of before you apply more Vaseline on, but children hate they absolutely hate the faces being cleaned. It's a painful, distressing experience. So I definitely recommend they clean the face in the morning with sort of lukewarm water or cool water, clean it and then apply the Vaseline. Don't let it to dry out and just put more on, because as it dries out, the skin will crack and then they will itch and they will bleed and it could cause more damage for the skin long term. Okay,
very clear, thank you. Another question that came in is, I've always learned not to remove clothes, only diapers. I even followed a webinar last week and they told the same. I'm confused now. Can you help this person?
If you can easily take some clothes off that have been burnt, I would definitely take the clothes off, but if they're stuck, don't worry, just to leave them, and then when you seek medical help, they will help remove them.
Okay, very clear.
Definitely remove jewelry if you can as well, especially rings if the fingers swell.
Okay. Another question that came in is, what is the reason you cool with cold water instead of lukewarm water? Doesn't cool water induce hypothermia more?
It can be lukewarm water or cool running water. Getting hypothermia in children is a big risk, and if they have a significant burn, you put them under the shower or running water, they absolutely hate it. But it's a balanced risk. You need to keep them warm, but actually by providing the cool running water actually stops that burning process and potentially making that burn a little bit deeper later on. So it can be a combination of cool water or lukewarm water, depending what's acceptable for your child.
Yeah. Another question, there are quite some, Andrea, sorry.
Don't worry.
How do you assess whether a wound is a burn due to abrasion or a scrape, for example, from a bicycle?
It can be difficult if it's scrape. We see lots of children that have come off a bike or been hit by a car, and they've had, we call it like gravel rash. So we tend to, depending on the size of it and the significance of it, we do sort of treat it as a burn and class it as a friction burn. So we dress it according to the size of the burn. It is a little bit difficult and there is varying opinions on it, but we tend to sort of treat it as a friction burn.
Okay, thank you. Another question that came in regarding the current situation, namely, due to COVID-19, shared care is a really integral part of wound care now. How difficult is it to remotely advise parents on how to apply and remove silver dressings in comparison to flaminol?
Parents they've adapted really well to COVID. So when COVID first happened in the lockdown, we were a bit unsure how parents were going to manage, because before they always said they wanted to come to hospital, but I think the fear of coming into a hospital environment and catching COVID, I think they were scared. So we set up many processes. We've got something called Doctor, where we can do video consultations with them, and we can assess them doing the dressing at the time. They've done emails. We've got some parents have chosen to use WhatsApp and they send us video calls and they're callers. So we give them dedicated times, and if they do need to come into hospital, they'll come into hospital for the bigger dressings. But if they're more comfortable to do the dressings at home, they've been quite happy to, regardless if it's a flaminol or whether it's silver dressing. But we discuss with the parents and look at the size of the wound and the compliance of the child as well, because in hospital you tend to have a few more hands around to help do the dressings, and if parents are at home, they're single parents, it can be a bit more difficult. So we just assess each case individually. Okay,
perfect. Thank you, Andrea. Another question for you is, why do you only account for blistered skin when calculating the total body surface area?
The unblistered skin is erythema, so that doesn't get counted as part of the body surface area for the burn, because the skin's not broken away. They haven't. When skin breaks away, children are more at risk. Skin's your major organ in your body. They can lose their temperature very, very quickly. I don't know how to explain it. We just don't.
Okay, no, that's perfect. That's perfect. Very clear. How is infection prevention being performed at your burns units?
Infection prevention, our infection rate within our service over the last 10 years has been very minimal. With COVID, we fully wear our PPE. We have masks, gloves, aprons, visors, or goggles if we're sort of deroofing blisters. That's our sort of our routine infection prior to COVID, but we've just got the additional of wearing the mask at the minute, but our infection rate's very low, and we haven't seen any spikes in COVID within my area or sort of any other infections in the burns.
Okay, and then a final question for you, Andrea. Analgesia suggestions for changing bandages after the acute phase. Do you suggest paracetamol, NSAIDs, oxycodone, fentanyl, excuse me, or others?
So when children present at our emergency departments, we tend to use iron dimorphine or fentanyl, so intranasal. With the older children, we can use Entonox, and we use paracetamol and ibuprofen, the NSAIDs. And then we've got the other options of Oromorph. Lots of children, I think, after that first few dressing changes, when it can be really painful, they seem to manage quite well on paracetamol and ibuprofen. And if you have really, really good distraction, sometimes they don't even know you're doing the dressing when you're doing it. So I think it goes back to that individual patient, whether they're in hospital or out hospital, but we make sure we give them maximum analgesia depending on what their individual requirements.
Perfect, thank you, Andrea. It's very clear.